Hello, everyone. This is Bashar Qumseya with the Standards of Practice Committee. I'm happy to be here today to discuss our most recent guideline coming from the ASGE about the gastrostomy feeding tubes. And today I'm happy to be joined by the lead authors who did most of the work for this clinical practice guideline, Div Kohli, Natalie Cosgrove, and Wasif Abidi. Thank you guys for your hard work and for doing this guideline for us.
Thank you.
Thanks, Bashar, for the opportunity to the
Yes, thank you guys. So today we decided to do this guideline about PEG tube placement. Can you tell us why is this important for the practicing gastroenterologist to read this guideline and understand about the evidence behind this guideline?
Certainly. So, feeding tubes are something that we all do in our clinical practice. It's a very commonly performed procedure. And even though we all have a lot of experience in placing PEG tubes, the optimization of the procedure is always something that we are focused on. So our goal here was to look at all the data and figure out what are the best practices that we can use for helping our patients and make sure that we follow the latest evidence for placing these PEG tubes. So we came up with 4 questions which are clinically relevant and important to the patients as well as providers.
Excellent. And as always, we want to remind our audience that our guidelines today are based on the GRADE methodology, in which we did systematic reviews and meta-analysis when appropriate, and reviewed all the available evidence and came up with these guideline statements. Excellent. So we'll dive right into it. And Div, let us ask you, this is a common question. So somebody needs a PEG tube in the hospital. Should we do it endoscopically as gastroenterologists or as endoscopists, or should IR be consulted? What did we find as far as is any modality better than the other in terms of various outcomes?
Sure. So we did a systematic review and meta-analysis on this topic. We basically compared the outcomes with an endoscopic gastrostomy and an IR-guided gastrostomy. So we reviewed 33 studies, looked at all the data, and these included mostly retrospective studies, but there was also a prospective RCT. There was also 3 nationwide studies. And essentially, we looked at outcomes that would be important to the patients as well as to the providers. So we looked at mortality, peritonitis, and through all of this data, what we found out was that the risk of mortality, which is death, is higher with an IR gastrostomy. And IR gastrostomy is also associated with a higher risk of perforation of the colon, and more importantly for the patient's malfunction of the tube. So based on all these data, as well as input from other physicians, radiologists, as well as our patient representative, the ASGE came up with the conditional recommendation that for patients who have a normal foregut anatomy, an endoscopic gastrostomy is the better modality compared to radiology.
Yeah, thank you, Dev. These are very important outcomes, even though, as you said, we did not find any randomized trials on this topic. But the outcomes of mortality and perforation and tube malfunction are very hard outcomes and obviously are very important. So based on this, our recommendation would encourage all of us as endoscopists and gastroenterologists to try to be more involved in placement of PEG tubes, which is not a very difficult procedure to do, and making sure all of the fellows also understand how to do this safely. Excellent. Thank you so much, Div. All right, Wasif, what about, so you have a patient, you decide to do a PEG tube based on a consult, but the patient is on antiplatelets, maybe they had a recent stroke, maybe they had a recent MI, but still need feeding. And frequently we're questioning, should we stop the antiplatelets, or can we do the PEG placement on antiplatelets to minimize the risk of stent thrombosis or restroke or etc.?
Yeah, so sometimes holding the antiplatelets is just not feasible. whether it's medically or it's for logistics or because the patient is just going to delay their hospitalization. So we really wanted to look at whether these patients whether we need to hold the antiplatelets or not. And so we did an exhaustive literature review and found several retrospective studies. We wanted to look at mortality, cardiovascular risks, length of stay, overall adverse events, but really we only had significant data on risk of significant bleeding. What I did find was that there was no difference in bleeding outcomes, whether their patients were on antiplatelets or not on antiplatelets. So we recommend against routine withholding of antiplatelets at this time, including patients on dual antiplatelet therapy.
And Wasif, thank you. This is a change in recommendation because in the past, many guideline panels had recommended routine stopping of antiplatelets before PEG-2 placement, but we found that this really does not have a lot of evidence to back that. And essentially, even though we found the evidence mainly on the bleeding, but that was the main reason we wanted to stop antiplatelets, correct?
Correct. And there are a lot of centers that will routinely put PEG tubes in patients that are on antiplatelet therapy, and they don't have significant complications, and that's what these studies were showing. And so I think it's better for the patients. I think it's overall, this is an important change. And the way we think about this, that PEG tube placement is really not that high of a risk procedure, that it can be done. And obviously you have to do all the precautions that you need to do, keep an eye on these patients, but this is overall, I think, a good change to how we practice our medicine.
Yeah, a lot of this bleeding that you can notice, remember when we're doing PEG tubes, we're not using cautery. So we're using, blade, we're using needles, and the bleeding that you get from these kinds of interventions is usually easy to control if it happens because there's no cautery involved. Okay.
Whatever bleeding we saw wasn't any life-threatening bleeding. Yes, it was significant bleeding, but it wasn't life-threatening, which is also reassuring.
Yeah, whereas if you do stop the antiplatelets, then this could cause significant adverse events, even though we don't have data on this because it's difficult to randomize patients in that manner. All right, excellent. What about anticoagulation, warfarin, etc.?
Yeah, so we looked at anticoagulations as well. Again, we didn't see any increase in bleeding rates, but the number of studies was very few. And given the wide confidence intervals, we didn't want to suggest any specific way for physicians to do what they're supposed to do. So we defer to the clinician, and we suggest that decisions be made after a multidisciplinary discussion, including the patient and the family, in deciding whether to hold the anticoagulations or whether to continue them.
Very good. In doing so, again, we did not make a specific recommendation to stop or not to stop the anticoagulants. So theoretically, you could, if the patient needs to be on anticoagulants, but also needs a feeding tube, you could the physician could elect to proceed with PEG tube placement without withholding anticoagulations if that is the right approach based on the risk-benefit analysis. Excellent. All right. Natalie, okay, so you have one of the more fun questions because you actually have randomized control trials on this, and we have some data. So, we did the right thing. GR was consulted. We did not hold the antiplatelets. We did the PEG tube. And the question is, when do we start feeding or using it for feeding or for medications? Should we start immediately, meaning as soon as we're done with the procedure within 4 hours? Or should we wait 4 hours or more to initiate the feeding?
Yeah, great question. For this, we also did a systematic review and a meta-analysis. We found 8 studies. Half of those, or 4, were RCTs, and the total patients in between all 8 studies was over 1,000. So a lot of patients examined. And we divided it into studies that looked at early feeding, which we defined as feeding within 4 hours of PEG placement, and delayed feeding, or more than 4 hours. And what we found was there was no significant difference in any outcomes. And we looked at several, including mortality at 30 days, short-term mortality, adverse events like vomiting, aspiration, peristomal leak, wound infection, and stomatitis. So again, no difference in outcomes. We wanted to look at clinical outcomes of early versus delayed, like lengthened hospitalization, et cetera, but couldn't find any data with that. But this should be reassuring to the readership that there is really no need to have delayed feedings, that early feedings are safe, and that there is no need to not do feedings even immediately. So for the recommendation, we had a strong recommendation due to the randomized controlled trial data, and recommended that in patients who undergo PEG tube placement, PEG tubes may be used for feeding early, which again, we defined as within 4 hours over routine delays in initiation. The 4 hours is somewhat arbitrary based on the prior data. The more important point is that you don't need to routinely delay, and as early as immediate, if it's appropriate for the clinical setting of the patient, is safe.
Excellent. Thank you so much. So this is very important because I know in clinical practice, a lot of practitioners sometimes would want to hold feeding routinely, and that could have deleterious effects on patients if you start delaying feeding and using for medications. Thank you so much, Natalie. Thank you so much. Last but not least, coming back to you, Div, in patients, a specific population here, patients who have malignant dysphagia, maybe esophageal cancer, maybe ENT. And there has been some data suggesting these patients may be at increased risk of tumor seeding from the standard pull approach. But there is a different approach that the gastroenterologist can use besides this. Do you want to tell us first about that approach, and then how do these two approaches compare?
Certainly. You're right. We do have some patients who have a malignant etiology of dysphagia, and as you mentioned, there's a risk of implantation. The thought behind that is, as the PEG tube is pulled through the mouth across the esophagus, that can pull some tumor cells and mechanically implant them at the site of the gastrostomy. The second technique is the transcutaneous or the direct PEG, in which case the tube is not pulled through the esophagus. Essentially, the gastrostomy is created and sequential dilators are used to dilate that tract. As that tract becomes dilated sufficiently, the PEG tube can be placed directly across the skin into the stomach. So there is no passage of the tube through the mouth. And theoretically, the mechanical translocation of cancer cells should not occur. So that is the second alternative that we talked about. So in this PICO, or in this question, we tried to look at the data behind this, tried to look at what is the true risk of implantation metastasis. And if we have a patient who needs a feeding tube in the setting of a foregut cancer, what options does the patient have, and what should the endoscopist do? So based on that, we did a systematic review of all the published literature. We did not see any prospective studies, no randomized controlled trials. We found one meta-analysis which we were able to update. And we also had to rely on expert opinion based on people who do this very frequently. So based on that, what we decided was we don't really have good idea as to why implantation metastasis occurs. We have made an assumption in the past that it's only because tumor cells are mechanically pulled along with the feeding tube. But there are also data that even with the other techniques for placing a feeding tube, we can still have implantation metastasis. There is also a risk that these tumor cells can navigate to the site of the gastrostomy through the bloodstream. So that was one aspect of it. Second aspect of it was the equity. We wanted to make sure that most patients have equitable access to clinical care. And these techniques that are described for the transcutaneous direct PEG tube placement, those techniques may not be available everywhere. So because of that, we gave a conditional recommendation. The ASGE gave a conditional recommendation to state in patients who have a malignant etiology of dysphagia, we can use a transoral or a standard pull PEG. But if you have the ability to do a transcutaneous PEG tube, you can do that as well. So we are really deferring to the clinician. The take home from this is that both techniques are feasible. When the patient is being told about the PEG tube during the informed consent process, the risk of implantation metastasis should be mentioned. And after the PEG tube has been placed, whenever the patient comes for follow-up, we should continue to be diligent, examine the gastrostomy site, and make sure there is no implantation metastasis that has occurred.
Thank you so much, Div. This is also a change from previous recommendations because most physicians, gastroenterologists, endoscopists would shy away normally, would consider this a contraindication. But as you mentioned, we did not find this to be an absolute contraindication. And traditional PEG tube placement is still an option in these patients with malignant dysphagia, so they should not be discounted. But this also is important because we're encouraging physicians as well, endoscopists in general, to consider this direct approach. Many of us are not trained to do this during our fellowships and only know how to do the endoscopic approach. But the direct approach, which is similar to what IR would do, is also feasible to be done by gastroenterologists as safely. And maybe this would spur interest in our trainees and training programs and anyone who does PEG tubes to consider becoming trained to do this as an alternative. Thank you guys so much again for your hard work on this guideline. I think this is a very important guideline. You know, PEG tube is commonly performed. It really helps a lot of patients who are in need. And I hope that in having this guideline out, we can optimize the care for these patients in terms of having endoscopists do more endoscopy, PEG tubes, not holding antiplatelets, starting feeding early, and considering PEG placement in patients with malignant dysphagia. Thank you guys so much. And everybody, thank you for watching this episode. You can have access to our guidelines, are available in GIE, but are also available on the ASGE website. And they're open access, free of charge. Anybody can have access to our guidelines. And thank you again so much. Have a wonderful day.